Welcome. I'm Michelle Cowles, Executive Director of Business Development at Rogers Behavioral Health, and I am your moderator for today's webinar on hoarding disorder. Joining me today are Dr. Brandon DeJong, Clinical Supervisor at Rogers Hinsdale, Illinois location, and Dr. David Jacobi, Clinical Director of our Sheboygan, Wisconsin location. Before we get started, I want to do a quick overview of the format. The webinar is scheduled for 90 minutes. There is no need to check in. To receive CE credits, you must be logged into the webinar for the entire program. A PDF of the PowerPoint slides and list of references will be available after the program via an email sent from ce-go.com. In addition, a recording of the webinar will be published on resources section of our website within a few days for you to rewatch. Our speakers will give a 75-minute presentation. Following their presentation, I will facilitate the Q&A session. If you would like to ask our speakers a question during the presentation, please use the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you simply click the Q&A button on the Zoom taskbar. I will review the questions submitted, then the presenters will address them during the Q&A portion of the webinar. Now I'll turn it over to our presenters.
Very good. Thank you, Michelle. Thank you, everybody, for joining us today. I'm Dr. David Jacobi, and I'll be starting us off today. First of all, disclosures. Dr. DeJong and I have nothing of interest to disclose at this point. Next slide. So our learning objectives today are twofold. One is to describe one hoarding-related belief and behavior, and then identify at least two strategies to enhance motivation for treatment. Next slide. We'll be covering a variety of things today. I'll do that kind of first third here. So I'll talk about diagnosis and assessment. We'll get into hoarding-related beliefs and behaviors and some very important associated features. I'll hand it over then to Dr. DeJong, and he'll talk about the cognitive model for treating hoarding disorders, goals of treatment, motivation and insight, which are very, very important for this disorder, specific treatment interventions that we use, and then he's going to apply those to a case example he'll present. Next slide. So I want to start out with a note about diversity, because this is really an essential kind of piece of what we're doing here. There's not a lot of data that we know so far on different ethnic and racial minorities. In the world of OCD and related disorders, Monica Williams has done a lot of really great research to understand how this looks, both OCD and hoarding disorder, within, say, the African American population. So there are some issues certainly that are of concern, certainly the underrepresentation of certain minority groups within these kind of specialized programs for OCD, anxiety, and hoarding, so OCD and related disorders. Prevalence, we're finding that the prevalence for OCD and other anxiety disorders is pretty much the same between African American populations and the general population. We also know that individuals of different ethnic and racial minorities are underrepresented in research. So we need to do a better job of accessing those individuals to be participants in the process. Next slide. Barriers to treatment. Many of you are very familiar with these, right? Costs, right? Having insurance to seek these specialized programs. Transportation, stigma, right? Stigma is, we're improving on that. People are more accepting of mental health problems, but it still exists. Fear of therapy or fear of the therapist, right? Not trusting that they have their best interest at heart or can really understand their experiences. Lack of awareness. So I just don't know about what constitutes hoarding disorder or OCD or other anxiety symptoms, not knowing about treatments, right? A lot of people don't know about what are the prescriptive treatments for different mental health problems. And of course, lack of providers trained to treat these very distinct issues, right? And having the proper and using the proper tools and interventions to deal with them. And then cultural barriers. Do we deal with these things within our community, within our family, or do we feel comfortable going outside of our group to seek mental health treatment? Symptom dimensions, how are symptoms described? Are these individuals then misdiagnosed because they're not using nomenclature that we're accustomed to, and therefore they may not receive appropriate care? And of course, comorbidity, right? A lot of people will present with a need really for treatment for, say, hoarding or OCD, but they have other complicating problems, right? They may have issues with depression or other anxiety disorders or what have you. And if a person is not skilled enough to perhaps treat some of these disorders, they may go with and treat the more secondary or co-occurring disorders instead of the primary concern. Next slide. So let's talk about an overview of hoarding disorder. Next slide. So why was hoarding disorder added to DSM-5? There has been, as long as I've been doing this over 30 years, a lot of scientific literature on hoarding disorder. We know it's fairly common, 2 to 5% of the population. We do know that those with hoarding disorder have not responded very well to traditional treatments for OCD. We have really understood hoarding to be a subtype of OCD. With hoarding disorder, again, we pulled that out into its own category now. And we've done that again, in part because the response to treatment, which for OCD is exposure response prevention and the use of antidepressant medications, it's just not worked very well for individuals with hoarding disorder. So we're looking for certainly a better understanding and more effective treatments for hoarding. We also know that most hoarders don't meet criteria for OCD. They are really, the hoarding itself is really the primary issue for them. Next slide. In terms of diagnosis, there's really 4 things I kind of want you to focus on here. One is that for individuals with hoarding disorder, there's this persistent difficulty discarding or parting with possessions. And then number 2, this difficulty is due to a need to save and anxiety with the thought of getting rid of or having to get rid of these items for reasons that we'll talk about in a bit. Not being able to get rid of these items leads to this accumulation of possessions, which leads to clutter. So I can't use certain rooms of my house or the kitchen or things like that because there's just so much stuff piled over everything. And then lastly, clutter leads to significant distress and impairment, usually across multiple areas of functioning. And of course, we want to make sure that it's not due to a medical condition or better understood as another psychological problem. Next slide. In terms of specifiers, we have with excessive acquisition. So one of the things that's actually very rewarding for individuals with hoarding is the acquisition of items, both things that are purchased at a regular department store, at a flea market, things like that, but also things that are taken that are free, sugar packets, straws, flyers that you see for travel, outside of hotels and things like that. Insight can be rated all the way from good to pretty delusional, but we have found that insight can be fairly poor for individuals as a whole who have hoarding disorder. There's also a lot of associated features that I'll kind of talk about more than once. I think it's good to understand these. One is indecision, right? How do I decide what things to keep or to donate or sell or what have you? And so because of that, I just avoid it. Perfectionism, it's often related to that indecision as well. I have to make the perfect sorting decisions, make the right decisions about items to keep or give away. Procrastination, as I said, there's a lot of distress and anxiety that's built up thinking about having to make those decisions about what things to keep. And so I just put it off until I have this big, pile of clutter in my home. There can be executive function challenges as well, difficulty planning or organizing tasks. So I'm not really able to stay maybe on task or know how to organize things effectively, especially when I'm trying to declutter. And then distractibility. Again, maybe very difficult to focus on one sort of a situation or object at a time. I may see other things that distract me during that process of sorting. Next slide. Research challenges, it's obviously been difficult to do this because a lot of folks with hoarding disorder don't present voluntarily. Usually they come in at the behest of a family member or a county agency or even a landlord who says, you got to get rid of this stuff. It's a safety issue, or this stuff is getting in the way of us having people over to the house. And so there's usually more pressure from other people to get that individual back into or get them into treatment for the first time. Most hoarders don't see this as a significant problem, so they don't, again, voluntarily present for treatment. Now, females are more likely to present to treatment, even though the prevalence seems to be about equal between men and women, or males and females. And then hoarding is about 3 times more common as people get older. So unfortunately, I'm now in that 55 and plus range, but those folks tend to have more struggles than people who are younger. Next slide. So assessment challenges, hoarding versus mess. What's the difference, right? The difference typically is in functional impairment. Messy spaces don't impair life function, right? So people can come over and I can have repair people come over and fix things without there being any problems with access or embarrassment or things of that nature. Hoarding represents more significant concerns and general unwillingness of that person to have people over for embarrassment reasons or just functional. There's no place to sit down, right, because of all the clutter. Hoarding versus collecting. So normative collecting is more organized. It's more systematic. Things are arranged. Things are displayed, usually by type or type of collection. And then normative collecting does not produce the clutter or the distress or any of that impairment that we see in hoarding disorder. For those of you who have seen the show American Pickers, sometimes they'll have an individual have a barn full of just stuff that looks like hoarding, but then you come inside and they've got their collection very nicely organized. It doesn't impair, it doesn't clutter up their space. In fact, they have great pride in that collection. Next slide. Other assessment challenges. This comes from the International OCD Foundation. I would encourage any of you who are interested in knowing more about hoarding, or even for your patients, to avail themselves of that information. Really good overview of a hoarding disorder, assessment, and so forth. So they'll ask questions like, do you have difficulty getting rid of items? Have a lot of clutter at home or in your car, right? That kind of thing. Often lose important items because they kind of get lost in the clutter. Feeling overwhelmed just by the volume of possessions. When you ask individuals with hoarding, they just kind of look at their pile of stuff and shake their head. It's just so much stuff that they have to go through and make decisions about. They may find it difficult to stop taking free items, right? In part because, as we'll talk about, that's really positively reinforcing. I enjoy it, right? I enjoy buying things. I enjoy taking things that are free, right? Buying things because they're on sale. Avoid inviting family or friends into the home because, again, of shame or embarrassment. And then, same thing, same reason for not letting people in to do normal repairs. Next slide. Hoarding and dementia. So as people age, or if they begin to struggle with dementia or Alzheimer's, they may find that the hoarding increases. And some of that may be that they just need to know and be able to see where objects are. I don't remember them otherwise unless I can visually keep an eye on them. So about 20% of people with dementia display some hoarding behaviors, but most hoarders do not have dementia. So for example, I had a couple of friends who purchased a foreclosed house, and the woman who lived there had some other issues, and she was just hiding her furniture really with hoarding items, but she really wasn't hoarding disorder. She had more other things going on, dementia, probably some paranoia and so forth. So you have to be very careful about when you're doing your diagnosis to make sure that there's nothing else going on that might impair their ability to benefit from treatment, for example. Next slide. Assessment rating scales. Again, the International OCD Foundation has these three measures available to you. So I would certainly encourage you to go and take a look at them. The Saving Inventory Revised is a 23-item measure. This can be done as a clinician administered scale or self-report. And it really just has questions about, do you acquire things that you don't need? Do you have difficulty throwing things out? Really all the stuff that we're talking about today. The hoarding rating scale, much shorter, 5-item self-report scale, asking the same sort of questions. And then lastly, one that's probably used more frequently is the clutter image rating scale. So next slide. And what this is there are a series of pictures of living room, a kitchen, and a bedroom. And hopefully you can see this, but as you go from the first top row, 1, 2, 3, and then 4, 5, 6, 7, 8, 9. So the bottom right is the most cluttered. And what you see is this progression of clutter as you look at the photos. And so this is an easier way for a patient to be able to say, oh yeah, my bedroom looks a lot like, picture 5, or my kitchen looks like picture 8. And so it's a nice way for us to kind of get a sense for how much clutter is really there. IOCDF will say 4 and above is really significant indicator that clutter may be an issue. The other thing that's really important that we can do as clinicians is to take photos or have the patient take photos of the different rooms in the house. It's a great way to get a nice baseline for us to assess, how bad is the clutter and the hoarding. but also as a way to assess progress over time, right? Let's keep taking that photo every couple of weeks and see how things are going. Next slide. Hoarding disorder, other diagnostic challenges. With hoarding disorder, the thoughts are not intrusive. They are not obsessional, right? Obsessions are intrusive, unwanted, repetitive thoughts, images, impulses, things like that. So they're not repetitive, they're not distressing. And in fact, they may actually enjoy the acquisition piece, right? The buying things or getting some free things from, McDonald's. There's really no urge to rid the home of clutter. As I said, a lot of individuals with this don't see that the clutter is as much of a problem as we might. They really only experience that distress when they think about getting rid of those items. And there is that kind of egosyntonic nature to hoarding disorder. Very limited insight, not recognizing that what's happening is really anything that's of anyone's business or of significance. OCD, on the other hand, they are the presence of obsessions, so intrusive thoughts, images, impulses that are repetitive, certainly very distressing, and they're resisted in some way. Compulsions are very common. If I have contamination concerns, I engage in washing. If I have doubt, I go back and check and so forth. And OCD tends to be more ego-dystonic, meaning I recognize that these thoughts and behaviors are, as patients would say, silly, senseless, crazy, weird, and so forth. So really a fundamental difference between these two. Next slide. This is a little more difficult to understand, but hoarding disorder versus hoarding within the context of OCD. So for many years, hoarding has been a subtype within OCD. Other subtypes being contamination, washing, doubt checking, need for symmetry, and then ordering and arranging. And so it consistently had popped up and still does as a subtype. What we find is that for those with OCD who have hoarding, there really is no pleasure derived from saving things. And the resulting clutter, which is typically unwanted and highly distressing, which is typically, so they don't feel that distress. They're not typically interested in the items that they save. Like most of us, they have some sentimental attachments to things, but not overly so compared to those with hoarding disorder. And then excessive acquisition is also unusual. What we do see is that hoarding in OCD, so as sort of a subtype within OCD, tends to relate to other symptoms of OCD. So for example, I may not touch items that are contaminated, so I can't discard them. And I sure don't want to give them away because maybe I'll contaminate someone else who comes in contact with that item. There may be problems with decision-making, right? So I can't decide what to keep or what to get rid of. Similar to what we see in hoarding disorder, but also a common feature that we see in OCD and certainly generalized anxiety. They also may avoid discarding because they have to check everything, check to make sure that they don't need it or might be of some benefit to them in the future. So they may take a long time to go through boxes and boxes of papers just to make sure they don't have it. What's important to note here is that if hoarding symptoms are distinct from the OCD symptoms, you can diagnose both hoarding disorder and OCD, right? So those things can co-occur. Next slide. So comorbidity and hoarding symptoms in African Americans. Again, Monica Williams, remember that name. She's done a lot of great work in this area. This is not necessarily a prevalence of hoarding disorder, but it gives you an idea that within OCD, hoarding compulsions are very common among individuals, among African Americans with OCD. So again, her conclusion is African Americans with OCD tend to have high rates of comorbidity, including hoarding compulsions similar to those of the non-Hispanic white populations. Next slide. Also, we tend to see that hoarding is not just a United States, Canada, Mexico thing, it's kind of global. So Nordsliden and colleagues looked at the prevalence of hoarding disorder in England, Spain, Japan, and Brazil, and really found that, guess what, it's just as common there as it is here. So it tends to be fairly stable across cultures. Next slide. Actual prevalence, we don't really have really great numbers, right? In part because most people don't come forward, right? They're only there at the urging of someone else. We do find from the data that we do have that about 18 to 30% of those with hoarding disorders have OCD, and that many have also social anxiety, generalized anxiety, and depression. So it's possible that some of these folks may present to your practice because of social anxiety, GAD, other symptoms of OCD and depression. And that's great, right? If you're able to uncover that the hoarding is an issue and they're feeling less depressed, less anxious, perhaps that's your buy-in as well to get them to work on some of the hoarding disorder issues. Next slide. Origins, again, family history of hoarding. It may be something, my grandfather and my mother and I do. It's just what we do. It's kind of part of our lineage. Family values regarding things like waste. In our family, we don't waste things. And some families are really highly sentimental, right? They hold every piece of artwork or scribble that their children create from early on. Information processing problems. We've talked a little bit about this. We'll talk about it again. But attentional problems, being able to sustain attention, especially as that relates to that kind of hoarding and discarding piece. Problems, again, with executive functioning, organizing things, knowing where to put things, for example, during that process of sorting or when new stuff is coming into the house. Considering too many facets of a problem, as opposed to being able to focus on one piece at a time. And then fear of making a mistake. What if I, again, make a mistake and give away something or donate something or put something in the trash that I really wanted to keep or could use? There's also Curios and colleagues looked at lack of warmth in one's family is a significant predictor of hoarding severity. And it's interesting, just anecdotally, I've worked with some kind of older adults who have been through, say, a late life, say, divorce. And the objects themselves are really a comfort to them. It's like a warm blanket. Having all the stuff around me really makes me feel better, in a sense. If everything was put away and organized and my room was barren, in a sense, with just furniture, I'm going to feel kind of disconnected and cold. So there can be something about that as well, of having stuff around you to make you feel that warmth that maybe you've been lacking. Next slide. All right, so in terms of these kind of other issues of information processing deficits, we were reminded this is really a brain problem, not a house problem. So easy for me to say, categorization. So compared to non-hoarders, those with hoarding have a difficult time putting their possessions into like larger categories. To them, everything is unique and special, right? What's interesting though is when asked to sort other people's items, they don't necessarily have those issues in coming up with these larger categories. So they see things as very unique and special, at least their items. In terms of perception, those with hoarding view items collected as meaningful, whereas others may just perceive the items as trash or unneeded. So they perceive them to be something very special or more special than you and I might. Decision-making. This certainly, as I said before, can be related to perfectionism. It can be difficult for them to process all the information needed to make that decision. So the mail comes in, as it usually does for most of us every day. I look at that pile and I go, I don't know what to do with these things, where they go. Should I hold on to this? Should I throw it away? So it gets tossed on the table and the clutter, continues to increase. Attention, it can have difficulty sustaining attention. So attention may be impaired also by things like depression, fatigue, or the many things that those with hoarding kind of have to recall on a regular basis. This can be more so an issue with decisions related to that sorting and discarding. So they may be okay with attention in other situations, but when it comes to sorting and making decisions about possessions, they may find that those attentional problems really get in the way. Perspective memory, difficulty remembering or carrying out tasks to do in the future. Also memory issues of having or needing to have those the objects as physical reminders, right? Everything is out there. I see where they are. I know where they are. I know when I need them, that kind of a thing. The problem is that when we use too many visual reminders and aren't organized well, it becomes problematic for us, right? Difficult to deal with that. And then complex thinking tasks. There have been studies done looking at sort of brain function and parts of the frontal and temporal lobes that are used for things like judging relevance and the importance of things are overactive among those with hoarding when making decisions related to that sorting and discarding that I talked about. everything to individuals with hoarding feels important. It feels like it's worthy of their attention. When making decisions, though, unrelated to their possessions, these parts of the brain are actually underactive. So it's almost like it's hyperactive and hypoactive in a sense. There's not seemingly not a middle ground, but that also can be remedied through treatment. Next slide. So there's a lot to unpack here, but a lot of different thoughts related or that are part of the hoarding disorder experience. Beauty and aesthetics, seeing the beauty in otherwise common objects. I look at something and see something just that's very special. And if it's special, I'm going to keep it. Memory, objects, even useless items may have a connection to a memory. This is really important. I tell people, what if somebody said, I want you to take all your pictures from your childhood and throw them away. Just get rid of them. Most of us would go, oh my gosh, right? That's a connection to my past. There's an emotional connection. And people with hoarding have that same connection, but to objects that you and I wouldn't think of as having that kind of connection. So cups, I remember this cup when I went to lunch with my mother the other day. So throwing away these seemingly unimportant objects may be very similar to what we would experience if someone told us to throw away our old pictures from our childhood. Utility opportunity. The person may say, this will be useful at some point to me or someone else. When the perfect set of circumstances comes up, I can use this. Uniqueness. This is a unique, special item. Nobody else has something like this. I'm the only one, right? So I'm obviously going to keep that if I believe that. Sentimentality, emotional attachment to objects. There's also something we call anthropomorphism. So inanimate objects having human-like traits. So, little kids will say, well, I don't want to drop my teddy bear because it could hurt them. People with hoarding have the same thing about other objects. The object will be sad if I give it away or if I throw it away. So again, I'm more likely then to hold on to it. It's distressing to think about doing that. Comfort. Objects, as I mentioned before, is a warm blanket. If I put items away or clear it out, I'm going to feel alone. And that I'd rather have the items out to keep me feeling that way. Safety, both physical and emotional. Objects as protective barrier from danger, or feeling the need to control possessions to maintain protection and security. Identity or potential identity. Individuals with hoarding are defined by what they own. If I throw objects away, I am throwing away my identity. So imagine that. If that's the way it felt by throwing a cup or a piece of paper away, you can imagine how difficult that process of sorting and discarding can be. Control. So I know where everything is located. I can visually see what I have. No one will tell me what to do with my possessions. In fact, if you make the mistake of throwing out objects for the person without their approval, they really can be reactive to that and actually want to hold on to it, sometimes out of spite. So Dr. DeJong will talk more about that. Mistakes. What if I make a mistake when sorting? What if I forget where I stored something or forget an object? Responsibility and waste. If I'm able to reuse something or recycle it or give it away, I should do that. And if I don't, I'm being wasteful. And if I'm wasteful, I'm a bad person. Completeness. I've collected the whole set of whatever it is, as well as backups just in case. Validation of worth. If I have or can use these things, then I am worth more as a person. This is evidence that I can use to show myself and others that I am worthy. And then socialization, it's really important. And it's really a good behavioral activation activity, actually, to get out and socialize with people of, a like mind to some extent, right? Going to flea markets, going to garage sales, going to the store, whatever it might be, does provide individuals with hoarding an opportunity to interact with people who have similar interests. So that's important. Next slide. Current conceptualizations, again, the hoarders do not want to reduce acquisition. They like the acquisition, so that's very rewarding. It's very positively reinforced. And hoarders don't want to discard, right? They don't want to make those mistakes that I talked about and feel that distress. So they avoid it, which is negatively reinforcing. Next step. Slide. Hoarding behaviors, again, is a bit of a review, but gathering, so collecting not only useless items, but also useful items. I may buy clothes that I could wear, but I never take the tags off. It goes in the room and I never get to it. And again, avoiding discarding useless items that naturally accumulate over time. And again, it's just so distressing, I want to avoid it. And if you've seen houses, or if you watch those hoarding shows, you get it. You understand why it seems so overwhelming. Things that are hoarded could be anything. Newspapers, magazines, very common. I'm going to get to it at some point. Paperwork, trash or food containers, especially if I can't use my kitchen, I may have to order in quite a bit. Clothes and toys, broken appliances. I have 10 lawnmowers that don't work, but I'm going to fix them, or I'm going to cull together parts to make one or two work. Bodily waste, hair and nail clippings. What if I get rid of my DNA? That would be terrible and awful. And then animal hoarding. So there used to be a show on the Animal Planet called Animal Hoarding. And again, these individuals believe they're doing something really important by protecting and saving these animals. Unfortunately, they're usually not able to care for them in the way that they need to be cared for. Next slide. Elderly populations, very special concerns that we have. So moving around a living space safely. They may not be able to use furniture. They may use their recliner as a place to eat and sleep and watch TV because their bedroom is all covered with stuff. Again, malnutrition could result from not being able to prepare nutritious food, hygiene issues, certainly fire hazards, risks of falling, right, if there's a lot of stuff on the floor, and generally unsanitary conditions. As I mentioned earlier as well, problems with depression, anxiety, OCD. There may be deficits with social skills and social isolation. As I'm getting older, and not only do I not want to have people over, but it may be difficult for me to get out and do things. So there's really that sense of isolation and depression, right, that can result from that. And then add on top of that, if that individual has dementia or other organic conditions, can just really make this situation very, very difficult. Next slide. Okay, thank you. Dr. DeJong.
Thank you very much, Dr. Jacobi. I will start off by talking about the cognitive model of the treatment of hoarding disorder. I think that an important aspect of hoarding disorder to consider is that, over and above the more dramatic looking and sensational aspects of the things like disorganization and collected items, we see that individuals diagnosed with it have significant and consistent difficulties in other areas. And it's important to keep these in mind when we're providing treatment, as it's going to inform how our interactions with them will likely go. Given the nature of their symptoms, both because they feel embarrassed or they might not want others to come into contact with their things, they tend to see relationships, sometimes significantly, decrease in both terms of how close they are with others, as well as how often they see others. We see that relationships between family members and friends, certainly, but also those between landlords and neighbors typically become pretty stressed. And this leads to, in turn, isolation, which we know even for individuals not diagnosed with hoarding disorder generally causes an increase in depression or anxiety. And when somebody's isolated, there typically aren't other folks there to help put the brakes on some of these hoarding behaviors, like acquiring items or to promote discarding. So being isolated is going to globally decrease their level of functioning. We also see difficulties with finances, as well as problems in the legal arena. I've worked with folks who have significant financial commitments to storage units, as well as difficulty with credit card debt when things like in-person or online shopping is a primary vehicle for acquisition. So we also see loss of equity in homes, as the state of the home typically decreases its value pretty significantly. When we think about who gets treatment for hoarding disorder, we typically see that it's not the folks with the disorder coming forward voluntarily. So it's been my experience that when I'm working with somebody who has a hoarding disorder diagnosis, they've either been brought in by a family member, which in my opinion is the better case scenario, or they've been referred by a local or a state agency, typically after a complaint by a neighbor or a landlord, or after a first responder or a mandated reporter observes the conditions of the home. I think it's important to keep in mind the add-on effects of this particular diagnosis. We're going to see an increased need for and a load on local health and mental health departments, housing services, animal control, elder service agencies, and intervening with these folks who have the diagnosis can help decrease this load for many, many people. What do we want to get out of treatment? Initially, we want to make sure that these patients are safe. Frequently, we'll see that their living environments pose a threat to physical safety. So heavy items or unstable stacks of items in their collection, boxes lining frequently traveled areas or stairs in their home. We typically will see too infestations or vermin that might affect the level of cleanliness in the home. And depending on the items that are hoarded, like food, animals, that animals might introduce zoonotic diseases and animals might themselves be at risk, as we've said. Looking at the diagnostic criteria, we can really guide our interventions, and we'll focus on the patient's acquiring and avoidance of discarding items that typically, again, look to an outsider like they don't have any use or they don't have any value. We'll also set as a goal the decluttering of the patient's environment, as well as to be able to use the rooms in their home for their typical function. So being able to use the kitchen to make food, the bedroom to sleep, the bathroom for hygiene, or the living room to have contact with others. We'll want to also increase the patient's awareness of the impairment or the distress that's associated with their acquiring and difficulty discarding, as well as increase their ability to tolerate the distress that's associated with increasing discarding and decreasing acquisition. So we ultimately want to see fewer items coming into the home, more items leaving the home, being able to use rooms for their intended function, and that the patient can tolerate doing all of those things. So we're hopefully also going to see downstream effects of making progress on the goal. So we'd hopefully see improved relationships, improved physical safety, all of which are going to contribute to increased quality of life generally. I've seen patients reconnect with family members, particularly those who are able to be involved in the discarding process. Typically, as we'll see in the case example, this is one of the primary reasons for making progress, reconnecting with family. I've also seen patients who have been more able to use some of the items that they were interested in. We'll talk about too in the case study, a patient who was collecting cooking implements was able to unbox them and actually use them in order to prepare food. Currently, there's not a wide selection of empirically supported treatments for hoarding disorder. And what is out there is primarily researched by Frost and Steckity and Tolan. And is something that they've put into their book, Buried in Treasures. So I'll put in a small plug for that here. I strongly recommend, if you should be working with an individual who has hoarding disorder, you have them read this book, Buried in Treasures, in addition to reading it yourself. The treatment typically starts with educating the individual with the hoarding disorder about how we understand that it begins, how we understand it's maintained, as well as how and when it becomes a problem and interferes with functioning that happens day to day. It's got specific exercises that patients practice in order to gain more proficiency in areas that people with hoarding disorder typically struggle with more than the average person. We'll cover it in greater detail later, but the focus is on practicing decision-making. For example, is this item important? Is it not important? Developing a system that can be used for organization, using exposure to tolerate distress when they're resisting safety behaviors, and to practice sitting with that distress until patients habituate or get used to that distress, and then challenging the way in which patients are typically thinking about their things. If we look at the maladaptive cycle that people with hoarding disorder tend to get stuck in, we see that there's something that causes them anxiety. They'll misinterpret how threatening or bad a consequence might be. So if I throw out that paper, I'm going to potentially lose something important, or that would be the wrong decision to make. They experience elevated anxiety because of that misinterpretation, and they engage in behaviors that are designed to decrease their distress. For example, refusing to get rid of items. Because they don't learn that they can tolerate that distress, they continue to engage in the safety behaviors. They don't learn that they can handle the distress, and the items tend to build up. And this cycle is negatively reinforced by that reduction in distress until it gets to the point that folks have a difficult time functioning in their homes. The treatment intervention targets the behaviors that patients engage in once they're experiencing anxiety. So when they engage in adaptive coping, so increasing discarding, avoiding acquisition, they're able to show themselves that they can tolerate their distress. So when they're next in that situation, they'll judge that the consequences are less dire, that they're increasingly able to handle their distress. And that is, they have a corrective experience. And the intent is that as these exercises are practiced, the patients are going to start to shift how they think about how threatening the situation is. And when they encounter a similar situation, they're going to more consistently display adaptive behaviors and adaptive emotional responses. One of the factors that sets those with hoarding disorder apart from those who have other diagnoses is insight. And what we typically see is fair at best. I had heard it put best by Dr. Christiana Bradiotis, and we had mentioned it earlier, that this is a brain problem. This is not a house problem. Folks with hoarding disorder think and behave fundamentally differently than those without it. And insight is definitely a factor. This is what interventions have to target. So initial studies using more classic CBT-based interventions in the 1990s typically didn't result in good or consistent treatment outcomes. And we know that folks with hoarding disorder, on average, they can be expected to have at least, they start with a 15% dropout rate in standard CBT treatment, if not higher. Typically, they'll maintain that they don't need any sort of help. When we're thinking about insight, we'll want to remember that it is most definitely a multidimensional construct. So insight in individuals with hoarding disorder typically connects to agnosignosia, or denial that an illness even exists in the first place, or the absence of, pardon me, awareness of its severity or its consequences. We'll see overvalued ideation. We'll see that they have a persistent belief that their items in their hoard or in their collection are potentially valuable. They are especially connected to or representative of themselves, their experiences, or other individuals, and that the tendency to hold on to those beliefs despite them being illogical. We'll also see that those with hoarding disorder typically tend to react defensively when there are family or therapeutic or local or state agency related interventions that these folks see as forcing them to reduce the quantity of their possessions. And this can be connected to the history that the individual with the hoarding disorder has with these folks, which also often includes some consistent interpersonal conflict. This can look like a lack of insight as well. I had a patient that I worked with, and she said, if I'm working with you and you tell me what you want me to do, just like they did, I'm not going to do it. In terms of insight driving treatment attendance, we know that only about 3% of folks with hoarding disorder are self-referred. Of those people, there wasn't evidence that there were cognitive issues that were impacting insight. Typically, these folks don't see the problem as one of disorganization or excessive acquisition or difficulty discarding. They tend to see it as limitations of outside factors, right? These unreasonable demands of their loved ones, or of the availability of additional storage space. I've run into this myself. In initial meetings with patients, it was pretty common for me to hear, I just need another unit at the use store it, and I'll be totally fine. That'll fix this problem. We know that only, again, a small minority, about 15% of those with hoarding disorder, acknowledge that their behaviors are irrational, and that most folks are rated by therapists and loved ones as having insight that's either fair, poor, or delusional. But those ratings are in turn connected to those therapists and loved ones' own report of their own frustration with the progress or the lack of progress of the person with hoarding disorder. So it's something to keep in mind. And we'll talk a little bit about getting more objective measures into the mix. So however we want to define it, we know that having low insight significantly impacts the course of treatment. So patients with lower insight are going to be less engaged. They're going to report smaller treatment gains. And depending on the stage of change that they're in, they might even not deny that they have a problem and refuse to participate to begin with. Knowing how a particular patient's lack of insight manifests helps us to kind of structure our interventions. So, for example, a patient who has agnosignosia and doesn't think a problem exists in the first place might buy into treatment more if it's framed as, well, what do we need to do in order to work together and get this local agency to stop harassing you, or get these relatives off your back. Let's help you get your home into shape so they can check their boxes on their form. And we can hopefully, as they start to engage, we can deploy some motivational interviewing techniques. For folks with significant defensiveness, for example, we'd want to make sure it didn't appear that we were taking the side of the family members or of the organizations with which they've previously been having conflict. The longer that I've worked with folks with hoarding disorder, the more that I've found increasing awareness of how the disorder is impacting their lives tends to be a central component of treatment. And I think that what we see in treatment interventions for other diagnoses, like body-focused repetitive behavior treatments that focus on tracking and objectively recording symptoms, I think they've got it right. And I think it can be a very helpful thing to borrow when we're treating hoarding disorder. So as we've seen, difficulties with level of insight tends to be consistent enough that it's included in the diagnostic criteria. So it needs to be a primary focus of treatment. And one of the best ways to start tends to be using some of the reliable and valid measures that specifically capture hoarding symptoms. I'll go over a few of those in a moment. Ideally, we'd have collaterals involved to fill out those same forms. Hopefully the clinician would be able to do so as well, so we'd have multiple points of view. We would also want to take advantage of broader retrospective interviews with collaterals. So we should expect, as we mentioned before, that the relationship and the history with the patient is going to impact the picture that those interviews paint. Given how pervasive motivation and insight issues are in hoarding disorder, and that we want to work to increase both, we don't need to reinvent the wheel, and we can rely on interventions which are typically found in motivational interviewing. So having somebody kind of quote unquote tell their story and review how they got here can help them help motivate them to begin to change, particularly when they're able to review when it began, when it got out of control, and how significant others or family have reacted, what they've lost because of how they've tried to control it in the past. This can help with that motivational interviewing developing discrepancy piece. One of the interventions that's helped me most consistently is a visualization exercise from Buried in Treasures. Typically, we would have a patient go to a cluttered area of their home and either sit or stand in a spot that let them see the whole room. We'd ask them to rate their discomfort, record their feelings, their thoughts, and their beliefs about the room as it was in that moment. They'd then visualize the room without clutter, importantly, not how it was decluttered, just that it was. And they would record those same things and imagine what they would be able to do with an uncluttered room, arranged how they wanted it, as well as their discomfort level with having the room uncluttered. Especially at the outset, patients typically come into this kind of treatment with significant ambivalence, and really focusing on validating that, particularly with patients who tend to respond defensively, has helped me get folks to buy into treatment. And back when I was working with these folks, our treatment team were typically some of the very first people that these patients had say to them that decluttering might be something difficult, or it might be something that they don't necessarily want to do. One of the difficulties that connects to motivation in the treatment of hoarding disorder is that sustaining it can be difficult. So typically, if we're progressing through treatment as we should, patients are going to be practicing making decisions that are difficult and they might not be pleasant for them. As a result, after the initial shine has kind of worn off of treatment, motivation can wane. So the motivation to alter behavior in motivational interviewing depends primarily on two things. First, folks need to be confident that the change to be made is possible in the first place. And second, that it's important to make the change. If the patient's confidence that change is possible decreases, we're likely going to see that they're going to change how they perceive the situation rather than how they perceive their behavior. So, oh, I don't think this level of clutter is so bad. I don't really need to fix this. The importance of making a change refers more to the difference or the discrepancy between where we are at present and where we want to be in the future, right? So what will the consequences be of changing versus not changing? That is, am I where I want to be based on what's important to me, based on my values? We'll typically get at this with those visualization exercises. As we discussed so far, patients' level of insight can make it difficult to get accurate information about what they're able to do, how things look, or how they typically interact with their collection of items. And because of that, it's critical to use validated measures with them and with their collaterals. It was always a great help to me to use the specific answers to the rated items in these scales to tailor the interventions, as well as to administer them on a regular basis in order to have some concrete numbers with which we could track progress. So I'm including here a few frequently used scales along with typical scores for folks diagnosed with hoarding disorder versus not. They're in here for your reference. I will go over those briefly. First, we've got the saving inventory revised. It consists of 23 items. They give 3 subscales. So clutter, the amount of clutter in the home, as well as the difficulties associated with it. Difficulty discarding, that measures discomfort with removing the clutter. And excessive acquisition measures the degree of compulsive buying, as well as the acquisition of free items. The hoarding rating scale, as we mentioned before, it's a semi-structured interview that can help get at those same constructs of clutter, difficulty discarding, and acquiring, as well as the patient's rating of the distress and the impairment that are experienced as a result. This is typically helpful as it's able to give pretty rich information about the meaning of the items, as well as the vulnerabilities, the feelings, the values, and the goals of the patient. The clutter image rating, like we discussed previously, folks are rating the visual similarity between a given room in their home and a sample of 9 versions of a cluttered room. It's typically helpful for the patient, collaterals, and the therapist to fill this out in order to have a gauge on level of insight, as well as for progress during treatment, which, as we mentioned before, can be supplemented by the patient taking pictures of rooms that they're working on. Anything greater than a 4 represents clinical levels of clutter. The activities of daily living for hoarding scale looks at the extent to which the items in a patient's home interfere with their ability to engage in basic day-to-day activities like preparing food, using the bathroom, moving around one's home, or even being able to exit it quickly, or even find important things like bills or tax forms. So what do we do to start treatment? So as we said before, we really want to involve collaterals, so family members, significant others, and have them use the measures that we just mentioned in order to have consistent data about progress. And the best intervention that we have uses exposure to resisting acquisition, so being in situations or being around items that one would typically acquire, so items are not continuing to be brought into the home, and also practicing discarding of items that are already in the home, showing that these things are doable as long as we're practicing them consistently. That typically helps empower patients and hopefully increases their level of motivation. Once they're able to see that it's not this impossible task and that they can do it consistently, that's typically where you see that inflection point with folks' motivation. At the moment, again, there's one empirically supported intervention that's been examined by Tolan, Frost, and Steketee. So again, we're going to educate folks about hoarding disorder, how it begins, how it's maintained. And as we just mentioned, it involves that graded and progressive exposure exercise to avoidance and safety behaviors, as well as explicitly educating patients on how to make decisions about the items in their home. And we'll cover that in a little bit, as well as helping them challenge the way that they think about those items and developing a system for them to organize those items. Very briefly, we've been discussing exposure-based interventions. So as a quick review, what we mean by that is having a patient practice engaging in a behavior that causes them distress without them engaging in a safety behavior, like avoidance or distraction or reassurance seeking. If folks are successfully able to refrain from those safety behaviors, we see that they experience habituation or a decrease in their anxiety, despite dropping those behaviors that they use to artificially or quickly lower it. So upon subsequent trials, we typically see that gradual decrease of the peak anxiety as well as the duration of their anxiety. Typically, when we would start, we'd want to educate patients on how these behaviors stick and why it's understandable that they do from a behavioral perspective. As we've said, it can be pretty egocentric to acquire, as I'm sure everybody listening has had direct personal experience with. It feels good to get that thing. It can go a long way toward helping patients feel understood by saying that it makes sense why they are doing what they are doing. We'll have people track their acquiring as well, having them record every item that comes into their home down to bags and receipts, things from yard sales, things that were found on trash day, or even in some cases, things that were stolen. They list what they got and how uncomfortable they would feel if they hadn't gotten it. We help them to understand their process of acquisition, which typically starts with an emotional vulnerability. It could be excitement about acquiring. It could be feeling down and overwhelmed and wanting to feel better. It'll involve a trigger like seeing an item or finding out an item is available, having thoughts about the usefulness and the value of that item. There will be that immediate emotional payoff when the item is acquired, which then reinforces the acquiring. And typically this cycle ends with feelings of regret and negative thoughts about oneself. We want to help shift their thoughts about acquiring by setting specific rules and asking questions about the item, right? So I can't get this unless I have the money for it. I'll use it within a specified period of time. I've got room for it. or if I need it rather than I want it, and so on. As we mentioned before, we'll have patients practice not acquiring by being exposed to thoughts about items or to actual items in situations where they would normally acquire, and then not doing so. Typically, they're going to make a so-called non-acquiring hierarchy to guide the exposures, start with the easier items, work their way up the hierarchy as doing those exposures becomes easier and the urges to acquire become weaker. We're also going to want to put in place alternative activities for these folks to engage in order to provide a replacement for the enjoyment that the acquisition provides. Things like being more socially active, going to the library, adult education classes, or community meetings have typically been helpful. When we're working on increasing discarding, Frost and Steckity have a concept for patients called the practice muscle. So patients are consistently encouraged to work daily. We want patients to consistently practice for 30 to 60 minutes per day, working up to that amount if we need to, in order to be as consistent as possible and consolidate the learning that they've made. We'll typically find that patients have difficulty sustaining attention and motivation, as we discussed before. So we're going to want to find a way to work around that by identifying particular activities, particular times of day that are going to best support them. So if somebody's a night owl, they might do this stuff later. If you're an early bird, you might do it earlier. Patients might practice delaying distractibility, so setting and incrementally increasing a timer during these activities, turning off the TV or turning off the radio. We've even had folks put up sheets to cover things that aren't immediately being worked on so they don't get distracted. Patients are going to need to develop problem-solving strategies that are systematic, as folks who hoard typically have difficulty being systematic when they're solving problems. And there are many strategies for this. There's a lot of good acronyms out there. The one I typically use is RIBI, where we teach people to identify the problem, propose solutions, have them evaluate each one, pick the best one, the one that they think is going to be the most successful, implement it, and then see how it works. And if it didn't pan out, they would iterate through that process again. We'll have patients create strategies for organizing their things. They'll make categories like things to keep, things to let go of, and then additional categories like trash or things to give away, things to sell. They'll select the location for each category or use boxes or bins with the category written on it. And they'll move those things to interim and eventually final locations. Working with local recycling centers and charities can help with the items that are being let go. One important note about paper items, many folks who hoard mix important items, so bills, tax forms, money, with unimportant items like receipts or flyers or magazines. And these should be gone through very carefully. One person that I worked with in the past discovered an envelope that had a couple $1,000s worth of cash under a stack of magazines. So as we did when we were working with patients to reduce acquisition, we can come up with a list of questions to facilitate discarding their items. And we'll typically have them describe their thoughts about a particular item and then go through a series of those questions about it, right? How many do I already have? Is that enough? Have I used this thing in the past year? Do I plan to use it in a reasonable time frame? And does this seem important just because I'm looking at it right at the moment? We'll work with them on the importance of consistently following through after they made a decision to discard an item. It's going to be absolutely critical that they discard immediately after making the decision. If something sits around, the doubt that they made the right call to discard it is typically going to begin to creep in, and we need to keep in mind that the goal is going to be to immediately reduce the clutter in that moment. So we'll go over a case example. For the example, I'll be discussing a patient that I've worked with previously. I've changed some details to protect her privacy. We're going to call her Betty. Betty is a 66-year-old Caucasian female. At the time of treatment, she lived in rural Wisconsin. She had reported hoarding behaviors that were reaching back through her childhood, although she had always had somebody around who could help her declutter. So first it was her parents, then it was her husband. She had earned a PhD in rhetoric, and I mentioned this for a couple of reasons. First, hoarding disorder is an equal opportunity disorder. It cuts across age, race, gender, sex, socioeconomic status, education, IQ. And from what I've seen in the literature, there isn't a particular factor that is consistently associated with hoarding more than any other. I also mention it because when you're working with a patient who has this diagnosis, you are going to have the consistent experience where they argue to keep their things for many reasons. And Betty, having a PhD in rhetoric, was very, very good at this. And we need to keep in mind that we always need to be focused on reducing acquisition and increasing discarding, and we have to hold firm to that. There were many times when Betty made some arguments that I thought she had some solid reasoning behind, but had we gone with those every time, we wouldn't have made progress. Her husband had passed away a couple of years before she and I met, which is important for a few reasons. First, we see that when a spouse or a loved one or other support person is ill or injured or has passed away, it typically takes the brakes off of the hoarding behaviors, as there's no outside assistance for moving items out of the home, as was the case here. Betty has 2 children who are both adults and 3 grandchildren. At the time we were working together, Betty had only seen her grandchildren at her kids' homes, and her kids would not bring them to her home. They thought it was dangerous. They thought it was too cluttered. And this became a critical factor in motivating her to participate in treatment. We were connected with her as part of a study through a local clinic, and we used the intervention I had mentioned earlier from Buried in Treasures. This involved a therapist-led support group that met weekly to go over 1 chapter per week from the book. We'd plan to assign homework based on the content of the chapter, and we'd also meet separately on a weekly basis with the participants at their homes if they were willing to do so. Betty completed a retrospective interview as well as the measures that we just went over. We also included measures that assess depression and normative functioning for folks that are over 65. As we went through the retrospective interview, it became pretty clear that Betty had several of the things we had come to expect from older age individuals present in her life, folks who were diagnosed with hoarding. She had recently experienced a decrease in the involvement of her adult children because of the conflict we had previously spoken about. They thought her home was dangerous. They thought she was unwilling to change, so they had pulled away. Additionally, her husband had passed away, and as we had mentioned before, he was the primary driving factor for discarding these items. In the last couple of years, she'd had a decline in her physical functioning. So it was hard for her to get around due to arthritis, due to a recent fall where she had broken her wrist. This had healed up by the time we were working with her, but it was still a factor to consider. We found that she had particular beliefs about her possessions as well that made it very hard for her to let go of items, as well as contributing to the desire to acquire. And we were able to define her process for acquiring items that she was still engaging in. More on that in just a minute. Her scores on the other measures indicated she was spending an extensive amount of time acquiring, and this was causing her significant difficulty, distress, and impairment. For example, she was unable to sleep in her bed. She was instead using her bed as an area to store boxes of items that she had ordered online. She was sleeping in a recliner. She couldn't have friends or family over, friends because she was embarrassed about the appearance of her homes, family because they thought it was dangerous. She was also spending money that she didn't have in order to purchase things online. She had a comorbid diagnosis of major depressive disorder, which we also treated, but we didn't suspect any cognitive issues. You'll see I've got 2 ratings for the clutter image rating scale. I've got a 4 and an 8. This is because when I went to her home, I had finished the initial evaluation. We administered all the scales. She had taken me on a tour of her home. I had globally rated the home at a 4, which was the minimum level where we'd consider a hoarding diagnosis. I had my hand on the doorknob. I was ready to go. And I was thinking, all right, this meets criteria. I've seen more clutter, could be worse. And she said to me, oh, you should probably see the barn. And she ended up showing me a barn out behind her house that was filled almost floor to rafters with items from her collection. When we put together her treatment plan, we wanted to make sure that we took several things into consideration. So her relationship with her children, as we've already mentioned, but that with her neighbors as well, as what she was saving, particularly out in the back by the barn, was attracting vermin. So it was attracting mice and rats that were being noticed by and having to be dealt with by a couple of neighbors. With the loss of her husband, her withdrawing from previously enjoyed social activities because of her depression, and the decrease in contact with her kids and grandkids, she was increasingly socially isolated. She was experiencing financial difficulties. Again, she was living on a fixed amount of money, and she wasn't able to keep up with the fees that were being charged by the storage facilities that she was using. She wasn't very familiar with mental health treatment. She had never had any before, so we had to do some psychoeducation with her about the relationship between her behaviors, her thoughts, and her emotions. And as we mentioned, she had been having a decline in her physical capacity to the point where her hoarding was a legitimate safety concern. So as an example, after touring the basement for the initial assessment, we went back upstairs and I had to catch a stack of newspapers that was taller than I was after she bumped into it and almost fell. She was unconcerned about it. She said, don't worry, it happens all the time. So clearly this is something that would happen. If it happens frequently, it's a danger to her. We also needed to take into consideration that she was living in a rural area that gave her ample opportunity and space for acquiring. Tends to be harder to hoard and not be noticed in more urban areas, but having access to more space in a rural area can make folks more hesitant to realize how the hoarding interferes, right? I've got the option to just put things over here instead. What do their hoarding behaviors look like? So she saved several different categories of items from her children. She saved things beyond the typical keepsakes that parents typically save. She saved everything from school, not just art projects or pictures or report cards, but almost all of the documentation that was involved with having a kid in the school system, permission slips, reminders about upcoming school events, textbooks. Remember, her children were themselves in their mid-40s by this point. She'd also save information, which for her, it took the form of newspapers and magazines, which would be stacked along the walls of her home after they came in the mail. She'd drive out in her community on local trash day and see if there were any items that she would consider potentially useful, which had been put out. She'd put them in her car and she'd take them home. Typically, this was things related to art or anything artistic, small items of furniture. She'd also typically order items online that she would consider potentially useful either for herself or for someone else down the road. Pictures, art supplies, and for her, a big one was cooking implements. So the initial plan was to provide Betty with some psychoeducation about hoarding, almost exactly like we've done here, both in a more kind of one-on-one didactic way, as well as by having her read the Buried in Treasures book. So we plan to clearly describe the intervention, to work with her to develop a model of her behavior specific to her, where we really conceptualize that behavior in conjunction with her motivation for acquiring, as well as the feelings and beliefs associated with acquisition, with discarding, and particular feelings or thoughts or behaviors that might put her at risk to engage in maladaptive acquisition or to resist discarding. A particular piece of the treatment that was very significant was reviewing and coming up with a list of personal values, which really helped her kind of keep her nose to the grindstone and consistently participate. Over and above most other reasons, as we mentioned, was to be able to be more involved in her children's and grandchildren's lives, because that was something that she had gotten away from doing and missed terribly. As we moved into the intervention, I want to put in a word on the importance of communication. It's going to be absolutely critical to make sure that you are considered and careful about the language that you use when you're working with folks. I've worked with people with hoarding disorder who would jump at the chance to take something amiss and end the intervention. So please make sure that you're matching your language to them, right? Their collection, their stuff, their treasures, however they say it, and not anything else, particularly if you're speaking with a third person who's helping with the intervention, friend or family member, professional organizer, a case manager from a state agency. I have had more than one patient, or rather more than one third person, talk about the junk or the trash, which brought a very swift end to the home visit that was pretty typically hard to get in the first place. I hope it would go without saying, but working with somebody with hoarding disorder is a very, very good place for us to practice our poker faces, as you are going to be very closely monitored by these folks for how you react non-verbally. I think structuring this communication as coming from a place of wanting to help them be safe and be organized, as well as allowing them to set the direction and to some extent to set the agenda without being prescriptive about it, is going to help, as is avoiding touching their possessions unless you are given explicit permission to do so. I think too, coming at this intervention from a strengths-based perspective will be very helpful. So many of these folks have been told for a while by many people how their behaviors are maladaptive, unacceptable, they're out of control, and being able to show them that what they're doing well can be a strong source of motivation for them. The actual intervention had us come to Betty's house once a week to go over psychoeducation and to practice discarding, as well as planning for her to go on quote unquote non-shopping trips, she called them, and practice discarding on her own on the other days of the week. So we collected data on the how and the why of acquiring. We've gone over the how. Again, she would save items from her kids' lives in order to feel close to them and to show that she was a good and caring mom. She'd want to experience that sentimentality when she saw those items, and she had good memories of her kids. For the newspapers, magazines, art, cooking implements, she saw those as more things that provided utility, right? If not now, it was going to be useful to her or somebody else at some point in the future. The art she also acquired because it was to her intrinsically beautiful. She wanted to see it. She wanted to share it with others. And acquiring these items felt good, felt like she was doing something that was proactive, something that was useful, but she ended up not using the majority of them or putting them aside or not looking at them for months at a time. And they were getting to the point where they were taking up so much room that she couldn't use the rooms in her home. We also worked with her on creating other ways to experience enjoyment. So spending more time with her kids and grandkids rather than spending time with the memories of her kids. Donating items so that they could be used, and taking art and cooking classes instead of just acquiring those items. So to briefly review, she felt that the things that she collected were meaningful because they connected to her kids, they could be useful. She didn't want to get rid of them, particularly the newspapers and cooking implements, because she felt that they would go to waste. The feelings she experienced also connected to her identity. I'm a mom. I'm somebody who likes art. I'm somebody who likes to cook. They connected to sentimentality. I can recall fun and happy times when I look at these things. They connected to responsibility. I have all of this information and I have to preserve and take care of it. We worked with her on different identified vulnerabilities. So things like challenging perfectionism, tolerating feeling imperfect if things weren't saved. We worked with her to practice sustaining her attention, to practice appropriately categorizing items in her collection, and to kind of challenge her perception that collecting these things was not having any downstream consequences. We also educated her about the negative reinforcement that she was getting from avoiding discarding. So she would reduce her distress level by deciding to keep items. So she didn't want to potentially get it wrong and discard something that was going to be potentially useful to her or to somebody else in the future. So we practiced recording the consequences of discarding when we were working with her. And over the several weeks that we were with her, she recorded 0 times that she or somebody else wanted a piece of information or needed an item that she discarded. So for Betty, a critical piece of her intervention was motivation. And with her case, she had already started to consider that her acquiring and difficulty discarding was getting in the way of her important relationships. And we were able to have her write out on a whiteboard and prominently display in the kitchen with the values that she wanted to lean into, the goals that she wanted to achieve. So important for her to be connected to her kids and her grandchildren. It was important for her to be an educated person. So she actually very much wanted to help others who had been diagnosed with hoarding disorder. She was very diligent about learning the psychoed from Buried in Treasures and participating in the weekly groups. She had also identified honesty as a value and had framed getting those items but not using them as being intellectually dishonest about why she had gotten them in the first place. Her goals included, in addition to reconnection with family, to make her home safe, to be able to put up and appreciate her art, and be able to sleep in her bed without it being taken up by any items from her collection. We came up with specific rules for Betty and questions for her to ask when she felt the need to acquire an item. So would she use it in the next week? Was acquiring the item consistent with her values and her goals? Would not getting it help her with the work that she was doing for treatment? She'd carry a small notebook with her. She made a pros and cons list of acquiring items versus not. And as treatment progressed, the pros of not acquiring and the cons of acquiring did begin to carry the day. She also consistently completed her exposures to triggers to acquire, again, calling them non-shopping trips. She started by looking up new interests and hobbies online and not immediately ordering items. She'd sit with that discomfort until her distress decreased by at least half. After this didn't cause distress anymore, she'd move up her hierarchy and she would drive past and eventually go to bookstores. She would hold items and walk or drive on her neighborhood trash day and attempt to resist acquiring. She wasn't always successful. Some of her items needed to be broken up into smaller pieces, but she kept at it. She also developed a system for categorizing items at home. So she was broadly able to sort things into keep and discard categories. Keeping an item might mean that for herself, should it be able to be used in the immediate future? For her, it was within a week. Discarding might mean throwing something out or donating it or getting it to the person she was saving it for in the first place and then discarding it if they said they didn't want it. She also developed a storage system in her house. So being in contact with a local hoarding task force can come in very handy. We had professional organizers we were able to work with closely, educate them about the intervention, and they visited her during the week to build and to maintain that storage system. She'd also, as part of the visits, identify upcoming difficulties for the week and kind of plan or problem solve for what she was going to do when she was decluttering, when she was planning for an exposure, or when she would have to deal with neighbors or plan to visit her kids. One of my favorite parts about the Buried in Treasures intervention is that it devotes a significant amount of space to educating patients about and preparing to deal with what it calls the bad guys, or maladaptive cognitions or behaviors that typically come up in the course of treatment. So we might have somebody think, this isn't my priority, and we will set up a visualization exercise that we talked about earlier. They might engage in avoidance, and then we would set up a plan to keep working that practice muscle daily and put in place ways that we could be prominently and consistently responsible to ourselves and others. They might think that I want to go with the short-term payoff of acquiring and have it feel good. And we'd review the long-term consequences in addition to how we'd feel in the moment. We focused on maintenance and relapse prevention, where she was consistently able to have a treatment schedule. She worked on what we discussed previously in a consistent way and implemented those rules for organizing and discarding. One piece that Tolan, Frost, and Steckity discuss is that clutter begets clutter. And they kind of compare it to the broken windows theory, where Philip Zimbardo, he left a nice car in a neighborhood and nothing happened to it until he smashed a window out of that car. And within a day, the car had been stripped. So it's very easy for folks with hoarding disorder to say, my home's already cluttered. One more thing won't really make a difference. And Betty was able to use that to really challenge herself when she got the urge to acquire, and it helped her resist. And then finally, in terms of outcomes, at the end of the 3 months, her scores had decreased to where she didn't meet the cutoff on several of them, although she did still have an elevated hoarding rating scale and a clutter image rating score, primarily due to the items in the barn. After we had our last session with her, she was able to connect with a local therapist for support, and she continued attending and helping to run the weekly meetings of the Buried in Treasure support group. Since she's been able to spend more time with her family, she's been able to have her grandchildren over, and she's reporting a significantly lower sense of frustration and shame. She had put some of her art up on her walls, and as of a few weeks after we finished, I had gotten word that she was sleeping in her uncluttered bed. And with that, I will turn it over to the Q&A session.
Thank you. Now it's time to answer the questions, and there are so many good questions. So we'll try to get through as many as possible. If you do have a question, please use the Q&A button, not the chat feature on the Zoom taskbar. And I'll try to get through as many as we can in the time that we have left. If we don't get to your question, please send me an email message afterwards and I'll follow up with you. So the first question is, if disorganization is a key feature in the presentation of hoarding for a given client, how is that specifically addressed in CBT?
Go ahead, Brandon.
I think for me, what I would typically do is really kind of come at it from the standpoint of what are the downstream effects of this disorganization, right? So how is this impacting what you're doing in your life? How is this impacting the emotions that you're experiencing? So is the disorganization contributing to you feeling down or depressed? Is it contributing to you feeling anxious? Is it contributing to you feeling disconnected from your family? And I think kind of setting the stage with those things, that helps us then kind of find what's going to build in the motivation to have folks participate.
Thank you. Is collecting and keeping emails or computer files considered hoarding? And if so, how would that be treated?
That's the big question. That's kind of the new question for hoarding, is digital hoarding. So if I don't have a USB drive, if I had a USB drive in my hand and it had thousands and thousands of documents, which would take up an entire library's worth of space, would we meet criteria? And technically right now, no, we wouldn't, because that particular thing, let's say that's what I hoarded, unless the USB drives were taking up rooms and rooms in my house and stopping me from being able to use them, we wouldn't meet criteria. And I think it's going to be important to kind of take a look at some new research about, does saving those things, does kind of the ancillary add-on effect, do they also cause any impairment or distress in folks' life? I mean, certainly it takes up less space, but we know that there's a lot of other stuff that folks who have hoarding disorder tend to deal with.
Yeah, and I would add, we've had some people ask the question, what if I take photos of my objects and keep it that way? And I guess I tend to be more pragmatic, and I think, hey, if it allows you to get rid of the objects that are leading to the clutter, it's a great intermediate step. But I think ideally we would ultimately want them to discard the photos as well as part of that process.
Thank you. The next question is sending a professional organizer a viable way to treat hoarding disorder?
I think yes, as long as you very, very closely coordinate with them. I was very lucky because I was a member of the hoarding task force that was in the area, and I knew the professional organizer. And so she, very much like all of you poor folks today, was very used to hearing me prattle on about all of this stuff. And she really knew where she needed to be coming from a good CBT perspective. The average professional organizer likely won't. And that's not to say that they necessarily should, given their job, but it's extraordinarily important, I think, that you as the therapist are able to sit down with that person and really kind of structure things from both of your perspectives in order to not only use a good CBT perspective, but also so there aren't too many cooks in the kitchen and the person who you're working with is hearing different messages from different people.
Thank you. We did have a few questions also on the past 19 months during COVID. If you've seen an increase or is it harder to treat with issues like fear of not having enough food or supplies or even toilet paper, and how is that to be treated differently?
I haven't had any direct experience myself since COVID had started with treating folks with hoarding disorder, but I think all probably stepped a little bit closer to the diagnostic criteria than we might have previously. So I think, I could see for folks, they would likely be more socially isolated. I could see that there would be more of a motivation for them to acquire and hang on to things, particularly because this is going to be useful or this is going to be necessary. I would think, and I'm saying this without benefit of a study to support me on this, so let me make that clear, that if somebody who had hoarding disorder was put in a situation like the situation that we've been having for the past year and a half, 2 years, the motivation to acquire would likely be increased, that they would likely put more stock in, I'm going to eventually need this thing because I'm hearing that this thing is now in short supply. That would be my guess.
And there also have been several questions. You mentioned the ribeye method. Could you elaborate a bit on the ribeye method?
This is something that I will typically use with folks if we are working on decision making. So I'll pull it up here to make sure I'm getting the acronym correctly. So typically for folks who, hang on. Typically what we'll see is that folks need to, really kind of take a moment and kind of take stock, pause, and there it goes, and kind of relax, right? It's much harder to think clearly about a problem if you're stressed out about it. So they need to first relax. They need to identify what the problem is. What's the issue? How are things going to be different if the problem isn't there anymore? They need to brainstorm alternative solutions and write down all of the ideas that they can come up with, even if they're strange or silly or people think that they might not work. They need to evaluate each possible solution. So kind of rating each solution on a 1 to 10 scale. 1 means this isn't going to work. 10 means this is going to be a perfect solution for me. Y is say yes to one of those solutions. So out of all of these, I'm going to pick the one that I think works best. And then they're going to implement that solution. And then E is evaluate the outcome and the reward. So I went through, I chose one, I tried it out. Did it work for me?
Thank you. We had the next question. An increasing discarding step of that treatment, how important is it to encourage patients to make decisions about whether they keep something right away versus doing so later?
I know Frost and Steckety would say, make the decision as quickly as you possibly can, because if I make the decision, I'm going to throw away this box of tissues and I set the tissues aside without actually going through the process of discarding it, that's when that doubt is going to creep in. That is when we're going to start to second guess the decision. Oh, maybe I do actually need to acquire that. And that's the kind of thing where we want to practice not getting kind of caught in that cycle that, oh, but what if tends to be, I think, one of the driving factors for why this stuff tends to sit and not get discarded. So if it were me, I would say it's important to make that decision and then implement it immediately afterward.
Yeah, and I would add, we use the acronym OHIO quite frequently, only handle it once or maybe twice at most. But the idea here is to, once you've made that decision, it's a big decision to make, get that is into where it needs to go, and no rechecking. If you put things out for the garbage, don't go and search through the garbage again before it's picked up. The other thing that seems to happen as well is that when people are going through and decluttering, they come upon items that they haven't seen in a while. And they're sometimes renewed and refreshed with their interest in that particular item just by the process of sorting. So it can be, again, quite challenging to only handle it once to make that quick decision and move. But as Dr. Young just said, we have to kind of go with the flow and try to go with that resistance if there is any.
Thank you. Thank you for those answers. And we have more questions, but we are, that's about all the time that we have. If I didn't get to your question, please feel free to send an email to webinars@rogersbh.org. Many thanks to our presenters for taking the time away from your clinical practice to share your valuable insights with us. Helping a patient on the road to recovery means collaboration among everyone involved in their treatment. With locations across the country, our treatment teams are ready to partner with you. Rogers Outreach representatives are happy to answer questions regarding our treatment services, as well as learn more about your practice. Before we conclude, I'd like to ask our presenters to share a few recommended resources on this topic with our participants.
I mean, certainly Dr. DeJong has mentioned the Buried in Treasures book more than once. Great resource. There also is and I haven't seen it in a while, and Dr. DeJong can maybe comment on this, but the Treatments at Work manual that you can purchase. It generally is a therapist and a client manual that has you kind of walk through in a more organized way the process that he described.
Yeah, I have it sitting right over there.
Great. Thank you so much. That about wraps it up, everyone. I want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. About 30 minutes after the webinar ends, you will receive an email with a link to your personal dashboard on ce-go.com, where you will be able to access PDFs of the PowerPoint presentation slides, handout, and a complete list of resources. Those of you who have met the time requirement to qualify for CE credits will need to complete the evaluation to download your CE certificate to the event. If you have any questions about this follow-up email, please contact support@ce-go.com. go.com. On behalf of everyone at Rogers, we look forward to partnering with you to help you to support your patients. Thank you.